Bismillahirrahmanirrahim. It is my pleasure to be with you today to continue the continuous scientific activity of Bahia Foundation. And today our webinar is about the recent updates in breast reconstructive surgery. It is my honor to welcome Professor Nicolas Lemeria, the head of breast plastic and reconstructive surgery in Gustave Roussy, Paris. Also, it's my honor to welcome Professor Jean-François Honor, consultant of plastic surgery at Gustave Roussy. And our webinar today is about the recent updates in breast reconstructive surgery. And as all of us know, the aim of breast reconstruction is to reconstruct and maintain a permanent breast contour and provide bilateral symmetry. Also, re-establishing normalcy and maintain confidence and well-being. And as all we know that breast reconstruction, either it was autologous tissue or implant-based reconstruction or a combination of both implant-based and autologous tissue. So the most recent trend in breast reconstruction is the implant-based reconstruction and correction of the deformity post-reconstruction with autologous fat grafting. So this is recent articles that support that it is the upper hand now to the direct to implant breast reconstructive surgery, as we see in this article published on the gland surgery on 2019, that concluded that a single stage prepectoral direct to implant reconstruction is the state of the art in breast reconstruction and have found it to be safe and reproducible. And this technique is their primary choice for immediate implant-based reconstruction following mastectomy. Also, the use of autologous fat grafting for correction of post-mastectomy asymmetry is gaining an upper hand in breast reconstruction, and the concerns about the local regional recurrence is discussed in details in this systematic review and meta-analysis, and they concluded that autologous fat grafting is a powerful tool for breast reconstruction, and this study found that no increased risk for local recurrence after autologous fat grafting in patient subgroups evaluating cancer history types and other surgical modalities and post-operative radiation therapy, and thus provides a valuable evidence-based support for the oncologic safety of autologous fat grafting. So we focused today in this webinar on the two main issues on the recent updates of breast reconstruction is the autologous fat grafting and direct to implant in breast reconstruction. We will start now with, it's my pleasure to introduce Professor Nicolas Lemeria, the head of the plastic surgery department in Gustave Roussy, to give us a more detailed data about the autologous fat grafting indications and techniques in breast reconstruction.
Hello, everyone. Hello, everybody.
Hello.
So, first of all, thanks a lot for the invitation. I'm very pleased and honored to be with you today. It's a great organization. So, congratulations to Dr. Hassan and Khalifa for the webinar. So, my name is Nicolas Lemeria. I'm a plastic surgeon in Gustave Roussy. It's a cancer center in the south of Paris. And so we have an activity dedicated to breast cancer patients. So we perform carcinogenic resection, and breast reconstruction. Do you want me to start the presentation about fat grafting?
Yes.
Okay. So the idea of this presentation is to share with you our practice in fat grafting, how we perform the lipofilling, the fat grafting session for the breast cancer patient, and what are our main indication and contraindication to perform this surgery. So as you know, fat grafting is a powerful tool that you can perform for most of the patients who are demanding for breast reconstruction. So you can use fat grafting associated with breast implants. You can use it to improve the quality of your autologous breast reconstruction. You can eventually use fat grafting only to perform a whole breast reconstruction. And there's also few indications of fat grafting to correct aesthetic sequelae after breast conserving therapy. It means that there's a lot of indication. The surgical technique of fat grafting is quite boring, but again, because of the quality of the results that you can achieve with this technique, you need to be able to offer this technique to your patients. So first of all, few slides about the technique of fat grafting. As you know, the first stage is to select properly the patient and to be able to perform a preparative assessment of the potential volume that you can harvest. So there's a trick described by Roger Coury. So you can use the width of your hand to assess the different zones that you can harvest, and you will be able to harvest something about 50 cc of fat for the size of your palm. So it depends the thickness of the subcutaneous tissue, but it's something about 50 cc. So it's a good way to assess how much fat you will be able to harvest for your patient. After that, you need to keep in mind that if you harvest some tissue somewhere on the body, you will create some fibrosis. You will potentially create some sequelae for the patient. So it's very important to preserve the donor site. You don't need to harvest the fat from all the areas in one stage. So go each side by one. And you need also to keep in mind that sometimes you need to reuse these donor sites to harvest some flaps. So keep some of the main zones for the flaps to keep a second option if needed for your patient. And because fat is like gold for breast surgeons, it's very important not to harvest more than you can inject. So keep in mind that you will have to probably to go back to the surgery for this patient. So preserve the donor site. Regarding the way to prepare the fat, there's many devices who are proposed by the industry. Most of these devices are very expensive, but as you know, there's no consensus regarding the ideal technique to harvest and to prepare the fat. So you need to find your own way. In Gustave Roussy, we try to follow some very simple principles. So, for example, as much as possible, we try to harvest the fat without the use of local anesthetics, because there's a potential toxicity of these local anesthetics on the fat. When you harvest your fat, I recommend you to use low vacuum with a small cannula and small holes. It means that you will be able to harvest small fat lobules, and these lobules will have a better integration in the recipient site. You can eventually wash the fat to remove all the blood, all the oil, and to keep only the fat, the pure fat, to inject it. If you decide to perform some centrifugation, make it soft, so there's no need to go over 2,000 rounds per minute. And regarding the technique to perform the fat grafting, try as much as possible to deposit the fat in different layers if possible by retrograde manner to avoid any pressure on this fat. And keep in mind that the air is not good for the fat, so try as much as possible to limit the contact with the air. So in Gustave Roussy, we try to make it as simple as possible. So we use an infiltration with cold saline of 1 liter with 1 milligram of adrenaline. And to perform the liposuction, we use a wall vacuum, and we use a drain bottle to trap the fat. And for all these cases of breast reconstruction, we don't use anymore the centrifugation, so we use only the decantation. So it's very simple. There's no need for expensive materials. You can do it very simply, and it's still very effective. So in order to optimize the separation between the fat and the infiltration, you need to let the fat for decantation during 10 minutes. It's enough. After that, you just have to make the transfer from the bottle of drain to small syringas. So you can plug the large syringa with a small one. It's very important to reinject the fat with small syringas because you will reduce the pressure on the fat and you reduce the risk of damaging the adipocytes. So as you know, it works not only because of the reinjection of the fat grafting, but also because of the use of rigotomies. So you need to keep in mind that the idea is to reopen a new space to graft this fat. And to do that, it's very good to use a needle of 18 gauge. And this needle will be used to cut the adherences between the subcutaneous tissue and the deep layer. And by this way, you will reopen a space where you will be able to inject the fat very smoothly, and you will optimize a lot the quality of fat integration. So this is a technique to reinject the fat. So we use this small cannula, and you need to make these different layers of fat injection on the tissues that you need to treat. So the technique of fat grafting is quite simple, and it's very important to have a good contact between the recipient tissue and the fat to optimize the integration of the fat. And again, if you need to treat patients who had some retraction of the tissue, you need to perform this technique of rigotomy to release all the subcutaneous adherences and to create a new space to inject more fat. So first indication of fat grafting is to perform implant-based reconstruction. For many years, this kind of woman with indication of delayed breast reconstruction and with very poor subcutaneous thickness of the tissue, with adherences due to the radiation therapy, were an indication for a flap only. But now, because of the use of fat grafting, we have completely changed our indication of delayed breast reconstruction, and we can eventually offer implants also for delayed breast reconstruction. So the idea is to prepare the area with 1, 2, or even 3 sessions of fat grafting before the insertion of the implant. So the idea is to treat not only the area of the breast, but we treat also lower in the area of the abdominal advancement flap, the whole tissue coverage of the breast that you need to reconstruct. And again, to optimize the quality of fat grafting, you need to reopen the space between the subcutaneous tissue and the deep layer. So you need to use this technique of rigotomy to optimize your each session of fat grafting. So this lady had a first session of 190 cc of fat, and you can see how it improved the quality of the subcutaneous tissue. Second session of fat grafting, again, more than 200 cc of fat, and you see it's a completely different tissue now because it's thicker. There's no more adherences, so you have softer tissue, and by this way you are able to perform the delayed reconstruction with an implant. So like always, we assess the amount of skin that we need to perform the breast reconstruction. We perform this abdominal advancement flap to recreate a new pocket, and we can place a definitive implant to recreate the breast volume. So you can see the patient before the first session of fat grafting and at the end of the reconstruction. Another indication is when you have performed a DTI reconstruction, and because we use more and more prepectoral implants, we have now more patients with the visibility of the contour of the implant after the first stage, or patients with some rippling effect of the implant. So to treat that during the second stage of the breast reconstruction, we do fat grafting in the subcutaneous tissue and improve a lot the quality of the reconstruction. Another case of bilateral breast reconstruction with prepectoral implant, and you can see how with one stage of complementary lipofilling, you can improve the aesthetic result for the patient. So the second indication of fat is to improve the quality of reconstruction that have been performed with free flaps. For example, this woman had an indication of bilateral prophylactic mastectomy. So it was a BRCA patient. So we performed during the first stage a bilateral musculocutaneous gracilis free flap. The result is good, but there's still a lack of volume in the décolleté or in the lower part of the breast. So with just one more session of fat grafting, 200 cc on the right side, 170 cc on the left side, we achieved a more aesthetic result for the patient. We have also a lot of indication of fat grafting when we perform latissimus dorsi reconstructions. So for example, it's a case of a lady who had a first stage of extended LD associated with the abdominal advancement flap and concomitant lipofilling. So the idea is to optimize each surgery and to do fat grafting for each surgery. By this way, if you do a concomitant fat grafting during the LD reconstruction, you will be able to increase the volume of your breast reconstruction up to 200 cc. You will improve a lot the breast modeling because the flap will be used only for the lower part of the breast, and you can use the lipofilling just for the décolleté and the upper part of the breast. And again, it's a huge improvement for the patient. And the technique is quite safe. So again, if you decide to perform a latissimus dorsi breast reconstruction, and if you are looking for more volume, please don't use an implant, because if you use this implant, you will accumulate the morbidity of both techniques, the morbidity of the flap and the morbidity of the implant. So if you decide to go for an autologous reconstruction, you can optimize and complete the volume just by performing a few sessions of fat grafting, and the first session has to be performed during the first stage of the breast reconstruction. So how can you do that? First, you can inject directly the fat inside the pectoris major muscle. So as you know, this muscle is quite thick, so you will be able to inject a lot of fat inside this muscle. You can inject also in the distal part of the latissimus dorsi muscle. So there's no risk to damage the pedicle at this level of the flap. So you can inject a large amount of fat on the distal part. And you can also inject the fat directly inside the skin paddle in the subcutaneous tissue just below the dermis. And by this way, you can increase the volume of your flap. And if you perform a delayed breast reconstruction, you can eventually inject more fat directly in the skin flaps. You see here the fat inside the pectoris major muscle, so the décolleté is completely filled and reconstructed just with fat grafting. Another case of extended LD with abdominal advancing flap, so it means that the flap is completely buried and there's no visibility of the skin paddle. And to optimize the quality of the reconstruction, we performed a concomitant lipofilling of the tissue. There's also a third indication of fat grafting when you decide to perform a whole breast reconstruction with lipofilling only. So you need to select properly the patient, but for few patients, it could be a very nice option to perform breast reconstruction. So the ideal cases are patients who had a mastectomy with skin sparing or nipple sparing mastectomy with no indication of radiation therapy and unilateral reconstruction. So this patient needs to have a good donor site to perform whole breast reconstruction. So directly during the first stage, just after the mastectomy, we start to inject the fat not in the skin flaps because they are quite fragile. The vascularity of the skin flaps is quite poor. So we will inject the fat directly inside the pectoralis major muscle. So again, it will fill completely the décolleté for the patient. And you see the aspect of the muscle after the fat injection. So it means you have a huge volume in the décolleté. So you just have to repeat the sessions of fat grafting. So for this lady, for example, we perform 4 sessions of fat grafting to perform the reconstruction of the whole breast. So again, it was an ideal patient, unilateral reconstruction, no indication of radiation therapy, and good donor site to perform several sessions of liposuction. If you decide to treat patients who had received some radiation therapy, it's much more difficult because you will have a poor integration of the fat inside the tissue. It means more resorption. So you can still obtain probably up to 70% of integration, but the rate of resorption will be higher. So it means that probably you will have to do more sessions of fat grafting to achieve the same results. And you can have also some issues for the inframifold reconstruction. So sometimes we need to associate the reconstruction with an abdominal advancement flap to achieve better aesthetic results. So it was the indication for this lady to perform at the end of the reconstruction this abdominal advancement flap to recreate a natural fold for the breast. Beware also if you decide to do a whole breast reconstruction for bilateral cases, it's much more difficult. We did this bilateral reconstruction with fat grafting only because this patient had a failure on the right side of an implant. So we decided to fix the problem with fat grafting only. And we had to perform a contralateral mastectomy for the patient. So we complete the reconstruction of the contralateral side also with fat grafting only. But there's just few indications for bilateral reconstruction. Another indication of fat grafting is to treat sequelae after BCT. As you know, there's 3 main types of aesthetic sequelae after BCT. For some patients, you need to perform a contralateral breast reconstruction for type 1 deformity. In case of type 3 deformities, you need to make a complementary mastectomy and to perform a whole breast reconstruction with a free flap. But for type 2 deformities, you can offer fat grafting for the patients to treat some irregularities of the contour of the breast. So a few cases, you see here, there's lack of tissue in the inner part of the breast and some scar retraction. So for this patient, we did some Z-plasty to release the scar, and we did few sessions of fat grafting to fill the inner part of the breast to achieve a better symmetry for the patient. Another woman who had a complete retraction of the lower part of the breast. So probably a few years before, it could be an indication for a flap or a free flap, but now because of the possibility to offer fat grafting, we know that we can fix this kind of deformities just with few sessions of fat grafting. So you need to tell to the patient that the problem will not fixed in one session. We need to repeat the fat grafting session 2, 3, or sometimes 4 times to achieve the result. But at the end, when you have the complete integration of the fat, the result is quite stable, so you won't have secondary resorption of the fat. So what about the contraindication of fat grafting? As you know, when we inject fat, it's not only adipocytes, it's also growth factors and stem cells. And there are still some debates about the potential interaction between fat tissue and tumor cells. If you look on the literature, and especially all the laboratory studies, you will see that if you combine some fat cells, stem cells, and tumor cells, you will promote metastatic disease. So there's many studies that have shown that fat can increase the risk of distant metastasis. But again, it was only laboratory studies. If you go and look for clinical studies, all these studies have the same conclusion. There's no problem about fat grafting. It's a safe procedure, and there's no increased risk of recurrence for the patient. But keep in mind that most of these studies are inhomogeneous. For most of these studies, we have incomplete data. There's no prospective studies and a low level of evidence. Mainly because, as we discussed just at the beginning of the presentation, there's many different ways to perform fat grafting, and there's no consensus about the ideal technique to perform fat grafting. So this is why in 2015, in January, the health authorities in France gave us some recommendation about the possibility to use fat grafting for breast reconstruction. The first things to keep in mind is that there's no modification of the BI-RADS classification after fat grafting. The radiologist knows the difference between local recurrence and cyst oils or macrocalcification due to fat grafting. So what are the contraindications of fat grafting defined by the health authorities? So in case of breast conserving therapy, when you need to perform fat grafting to correct some aesthetic sequelae, the first contraindication is mammogram or ultrasound with a classification by RADS 3, 4, or 5. For this patient, you need to go for a core biopsy, so there's no indication to put some fat inside the breast if the radiological exam is not normal. The second contraindication is for patients who had a breast conserving surgery, but with non-insano resection. It means that these patients have a higher risk of local recurrence. So it's quite risky to do some fat grafting for this patient because they have high risk of recurrence. You need also to contraindicate this indication of fat grafting for the patient who had incomplete adjuvant treatment, and it's not so rare. There's up to 4% of the patient who didn't complete the radiation therapy, and up to 40 patients who don't take their hormonotherapy. So if they don't if they don't complete their adjuvant treatment, again, they have a higher risk of local recurrence, so we don't recommend the use of fat grafting for this patient. Another contraindication is patients who have metastasis out of control, and patients who have aesthetic sequelae of type 3. It means complete atrophy of the gland. So for this patient, for sure, there's no indication for fat grafting. You need to perform a complementary mastectomy and a whole breast reconstruction with a flap. The health authorities also gave us a delay before performing the first stage of fat grafting after breast conserving surgery. So they decide to respect the delay of 2 years to perform the first session of fat grafting. So we will see in the next years, probably with the new publication, if it's possible to perform the first session of fat grafting probably earlier for the patient. And the health authorities also gave us a recommendation to wait 2 years after the mastectomy to perform fat grafting for patients who have a high risk of recurrence. So there's two main risky patients: the patient who had inflammatory breast cancer, so you need to wait 2 years to perform the first stage of fat grafting, and patients who had breast sarcoma. During the first recommendation, they also gave us the indication to wait 2 years for patients who had high grade of DCIS and younger than 50 years old. But as you know, with the two publications of Chronovicts and Petit in 2016 and 2017, there's no more need to wait for 2 years for this patient. There's no high risk of recurrence for this kind of patients who had high-grade DCIS. To perform properly the surgery, you need to have a good assessment of the breast. So it's recommended to perform 4 or 6 months before the surgery, a mammogram, ultrasound, and MRI. So you need to combine the 3 radiological exams. And 1 year after the last fat grafting session, you need to redo the exams. So you need to perform again mammogram, ultrasound, and if possible, another MRI. So what are the main recommendations of the Ministry of Health in France? So after breast conserving therapy, if you decide to do some fat grafting, you need to wait at least 2 years of delay after the end of the local treatment. The 3 main contraindications are patients with BI-RADS 3, 4, and 5, patients who had positive margin after the breast conserving surgery, and patients who didn't complete the whole treatment of breast cancer. And you need to wait 2 years after the mastectomy before the first stage of fat grafting. In case of high risk of recurrence, it means patients who had inflammatory breast cancer and patients who had breast sarcoma. So you can understand that fat grafting is a very powerful tool. So you need to offer this tool to achieve good results for your breast reconstruction. There's so many indications of fat grafting for your patient. So you need to perform this procedure. It's quite simple. It's totally safe. But if you treat a lot of patients with fat grafting, probably you will have 1 or 2 cases of local recurrence after fat grafting. It doesn't mean that fat grafting is risky. It just means that it's breast cancer patients. So few of them will have some local recurrence. So it's very important now to have not only a local or national recommendation, but to have some worldwide recommendation to perform this technique of fat grafting for breast reconstruction. Thanks a lot for your attention.
Thank you very much, Professor Nicolas, for your elegant, detailed presentation. And I have get some questions for you. I hope that they can be answered now. The first question from Professor Ala Talat from the UK about the fat grafting, the use of fat grafting to improve the quality of the skin after radiation therapy.
So it's a very good question. So yes, we like to use fat grafting to improve the subcutaneous tissue after fat grafting, after radiation therapy. So the idea is to increase the thickness of the subcutaneous tissue first, but also because of the fat, you will increase the improve the trophicity of the skin. So if you want to do breast reconstruction, you need to have soft tissue, and the best way to obtain it is to do this fat grafting. So it's a very useful technique to prepare the skin before the first stage of implant.
Okay, another question about the timing of fat grafting, especially in post-conservative surgery. As you mentioned in your presentation, that the Ministry of Health in France recommended to delay it for 2 years, but as you know, there is many papers about the immediate use of fat grafting post-conservative breast surgery. So there is many questions about the risk of immediate fat grafting post-conservative breast surgery?
So for sure, we don't recommend the use of fat grafting during the same procedure of the breast conserving surgery. First, because you don't know about the margins, so you can eventually do some frozen section, but it's not a definitive assessment of the quality of the margins. So it's quite risky. And if you inject fat in the breast, you already did some dissection of the tissue. So the quality of the tissue is quite poor. There's not so good vascularization. So we don't recommend this. I think it's better to perform properly the oncoplastic technique to do breast remodeling. Wait and see a few months after the end of the radiation therapy if there's some sequelae or not. In most of the cases, there's no sequelae. And just if needed, you can go for fat grafting. But until now, there's no recommendation to use it during the first stage.
Okay, another question about the safety of fat grafting in the muscle, either in the pectoralis major or the LD flap. There's a risk of fat embolism, or how do you explain this?
If you perform the surgical technique properly, there's no risk of fat embolism. If you inject the fat directly inside the muscular fibers, there's no big vessels. So it's not the same risk than if you do buttocks augmentation. On the buttocks, the vessels are quite bigger. It's not the same in the pectoralis major muscle or in the ALD muscle. So if you do the injection properly, there's no risk of fat embolism. Beware of the subclavicular vessels because they are quite close to the clavicula. So keep a good control of your hand and don't go too deep. Probably you have a high risk of pneumothorax if you don't perform the surgery properly. The risk of fat embolism is something about 0. And if you decide to perform fat grafting in the LD flap, it's also very safe if you inject the fat only in the lower pole of the muscle. I don't recommend you to inject the fat in the proximal part of the muscle because there's the proximity of the main pedicle. So you can damage the pedicle and you can lose your flap. So it's not the idea of the procedure.
Okay, and then the last question about the fat grafting in the contralateral side, contralateral breast, the normal one for augmentation.
So it's a good question because in 2015 in France, it was forbidden to perform contralateral symmetrization with fat grafting. But now with the last recommendation, we can offer it to the patient. But you need to always discuss about the risk and benefits for the patient. And there's not so many indications to do a contralateral symmetrization with fat grafting only. But it's now something possible in France, but a few years ago it was forbidden.
Thank you very much for this elegant explanation for every questions. And now it's my honor to present Professor Jean-François Renard. And his presentation today is about the direct-to-implant breast reconstruction. Professor Jean.
Good evening, everybody. Thank you very much, Maher. I'm very pleased to be here with you in France, but I would love to be with you in Egypt. I hope everybody is fine, and I'm very pleased also to share this session with my friend Nicolas. Thank you for this beautiful presentation. And I'm going to try to share with you our experience about direct-to-implant breast reconstruction. So I don't know if you can see my screen. Is it okay for you?
Yeah, it's okay.
Okay. So direct-to-implant breast reconstruction. We love in Gustave Roussy this topic because everybody knows today the benefit for the patient of the immediate breast reconstruction, especially with the implant. Even we can do today very nice delayed reconstruction with flap or everything. But when you see this picture on the left side, you have in one surgery we had the mastectomy and the immediate breast reconstruction, and the patient has everything. She has the oncologic treatment, she has the reconstruction, and then everything is over. She can go for the adjuvant treatment, and everything is okay. On the right side, you have a nice reconstruction, but the patient has to wait at least 1 year or more to get the reconstruction. That's why today there is a real benefit for the patient about immediate breast reconstruction, and that's why we are doing more and more immediate reconstruction, especially with implants. Here you can see that between 2014 and 2019, the rate of the number of patients who have immediate breast reconstruction with implant is getting more and more bigger. And I think 2 years ago, we have performed more than 300 breast reconstruction with implants. Because of what? Because when you look at the guidelines in France, when you look at them, we don't have any absolute contraindication for immediate breast reconstruction. The only one is the T4D breast cancer. Even the patient will have radiation therapy, chemotherapy after the surgery, or if the patient has received neoadjuvant chemotherapy, she can have immediate breast reconstruction. So the only thing is that we have to reduce the rate of complication. That's why in that way, because of what we cannot delay the adjuvant treatment. If the patient will have radiation therapy or chemotherapy after the surgery, the reconstruction should not delay the beginning of the adjuvant treatment. That's why we have to have a very nice selection of the patient in order to reduce the skin necrosis, the infection of the implant, because you have to go back to the OR and you may delay the adjuvant treatment. That's why the first thing is to get a good selection of the patients, and we know that we have a risk factor. They are common to all the surgery, and we know that smoker patient, obese patient, diabetes patient, or patient with big breast will have more complications. So each factor is not a contraindication for the breast reconstruction, but if the patient has all these risk factors, it's better to delay the reconstruction. What about the DTI, the direct to implant breast reconstruction versus the two-stage? We know that two-stage is to put an expander during the first stage to inflate the expander. The patient will have radiation therapy, and at the end, 6 months later, at least, you can remove the expander or put definitive implant or flap. In our experience, we have the same rates of DTI and two-stage breast reconstruction in our practice. This is 50-50. Each surgeon has his own preference. I do prefer to put definitive implant, but in some case, when you have a risk factor, for example, if the patient have a high degree of ptosis, if the patient is big, if the patient is a smoker, I do prefer to use expander to reduce the rate of complication after the surgery. In that way, the patient can have the adjuvant treatment in the good way, and then I will go for definitive implant or flap. But my first choice when I decide to perform immediate breast reconstruction with an implant is to use a definitive implant. So the patient, for example, this patient, even if the patient will have adjuvant treatment, especially radiation therapy, I do immediate breast reconstruction. If the patient is okay with this, We know the benefit for the reconstruction. You can preserve all the shape of the breast, all the skin envelope of the breast. Sometimes you can preserve the neck, and we are doing more and more nipple-sparing mastectomy. So you put the implant, you preserve the volume, then the patient had radiation therapy or adjuvant treatment, and after that, the patient decides she can preserve and keep the implant, or she can change the modality of the reconstruction, and she can go for a flap. So the previous patient decided to keep the implant because the result was good. We don't have any capsular contracture, and we will see later that we have something to reduce the rate of capsular contracture even the patient has radiation therapy. Or sometimes the patient can change her mind. This is the case for the patient. She had right breast mastectomy with breast reconstruction, and then she had radiation therapy and then bilateral mastectomy, and the patient wants a flap, but with the implant or the expander, you can preserve all the shape of the breast. What about adjuvant treatment, especially radiation therapy? Today we have European guidelines to guide the radiation therapist to do the treatment correctly. Even the patient had expander, even the patient had definitive implant, independently of the implant pocket, the patient can have the good radiation therapy. And we will see later that today we are doing more and more prepectoral breast reconstruction, and we know that if you put the implant above the pectoralis major muscle, there is no impact on the radiation therapy. And when you discuss with the radiation therapy, they do prefer to have definitive implant because they don't have the metallic valve, the metallic magnet into the expander, and then they have homogeneous volume, they have a nice implant, and the patient can receive the treatment in a good way. So probably the last evolution in the field of DTI is the implant pocket. Is the implant pocket because you can see then that during the last 3 years, we have completely changed the way to do a direct-to-implant breast reconstruction, because in 2017, 80% of the patient had retropectoral breast reconstruction with the implant, and then in 2019, almost 90% of the patient has prepectoral breast reconstruction. So probably this is the last evolution and the best thing in the field of DTI. Why? Because of this. Look at this picture. The patient had 1 month ago a right nipple-sparing mastectomy with immediate breast reconstruction. And then the cosmetic result is very nice, but the patient is not happy. Why? Because when you see the picture, you have breast animation, and this event is only related to the position of the implant behind the pectoralis major muscle. So today the question is why use pectoralis? Why to use the pectoralis major muscle? Because you will see in the most of the cases breast animation. And the only thing to treat that is to go back to the OR to change the implant pocket, and then you will avoid to have breast animation. So today we are more than 80% of the patient had prepectoral breast reconstruction, because you have many advantages. The surgery is less painful, and you can see clearly the difference. The patients don't have any medication after the surgery, because mastectomy with prepectoral breast reconstruction is not painful. The patient can move very easily. She has a better mobility of the upper arm. If we have time, we can see a video of breast reconstruction in prepectoral pocket, and you will see that it's very easy. You have a really gain of time during the surgery, and it reduced the stay in the hospital. So we know, and probably the most important thing, important advantage for breast reconstruction in the prepectoral pocket is to reduce the rate of capsular contracture if the patient has radiation therapy after the surgery. Look at this study which compare prepectoral reconstruction versus subpectoral reconstruction, and the rate of capsular contracture decrease. The rate is decreased of a factor of 3. So you go from 52% of capsular contracture, and you go down to 16% of capsular contracture for a patient who have prepectoral breast reconstruction. We know that when you do prepectoral breast reconstruction, probably the main disadvantage is that you have to use ADM or meshes. They are very expensive. We don't have any reimbursement for this in France. But when you see all this advantage of prepectoral reconstruction, I think we have to pay for this. We don't have much more complication if you put the implant in a prepectoral pocket. The only things is when you have any doubt about the risk factor is to perform the reconstruction in a 2-stage and use an expander during the first stage. I will skip the video, and if we have any time, we can go back to this video if you want to see the prepectoral breast reconstruction. Maher, you will tell me if we have time to see the video. Even what, I will skip it. This is the way we perform prepectoral reconstruction with meshes or ADM, and this is the gain of time, because when you are performing the mastectomy, your assistant can prepare the implant and the mesh, and then when everything is done, just put the implant, put 1 stitch to fix the implant in the perfect position, and then the reconstruction is done. So it's very easy. This is another video. The alternative of the use of ADM or meshes is to use polyurethane implant. This is exactly the same thing. You can use it in a prepectoral pocket. Unfortunately, we don't have. I'm sorry. We don't have access to polyurethane implant in France, so we don't have any experience with this, but this has been described. Here you have example of DTI with prepectoral breast reconstruction. You have very nice result. Even the patient had received radiation therapy. You can see the result 18 months after the radiation therapy. You have a very nice result. Even the patient with big breast, this patient doesn't want any flap, and with 1 procedure, she had the mastectomy, the breast reconstruction, and everything is done. And we have a very nice result, very nice shape of the breast. Another example. The only thing, and probably Nicolas told about this before, the only thing when you perform DTI in prepectoral pocket is that you have to use fat grafting. So you have to perform 1 or 2 sessions of fat grafting to improve the cosmetic result, because the disadvantage of the prepectoral reconstruction is that you have visibility or palpability of the implant in the upper part of the breast, and then you have to perform fat grafting. Another example of rippling effect after prepectoral breast reconstruction, and then with 1 session of fat grafting, you have very nice reconstruction. This is an example of the capsula. When you use ADM, if the patient has radiation therapy, you can see that the capsula remains very smooth, and you don't have any capsular contracture. example, for patients with radiation therapy, very nice result. So for us, today is mandatory if the patient doesn't have any risk factor to give her the opportunity to have immediate breast reconstruction with DTI, even the patient had adjuvant treatment. What about the complication after the surgery? We have complication. Everybody had complication. The most important thing is to treat this complication as soon as possible in order to not to delay the adjuvant treatment. And when you look, I'm sorry, the slide is in French. When you look at the beginning of the adjuvant treatment, we don't have any difference if the patient had breast reconstruction or not. If you compare only mastectomy or mastectomy with immediate breast reconstruction with the implant, we don't have any significant difference in the field of the beginning of adjuvant treatment. The rate of implant loss is about 8%. And you will see that in the group of prepectoral breast reconstruction, we have probably the same rate, and this rate seems to decrease a little bit. Most of the patient, 40% of the patient will have radiation therapy on the implant. The oncologist does agree with this. The radiation therapist does agree with this. We don't have any trouble with our colleague. So they have seen the real benefit for the patient of the reconstruction. This is the group of the prepectoral breast reconstruction, and you can see the rate of implant loss is about 7%. And when you look at the literature, we have the same rate. This is the mean rate of complication for immediate breast reconstruction. And you can see the most common complication is the skin necrosis. That's why we have to pay attention about the patient selection, about the surgical technique to reduce this rate of complication. So today, to conclude, we have everything to give to the patient the opportunity to have immediate breast reconstruction, to preserve the quality of life, to improve the cosmetic results. The patient can get the adjuvant treatment in the good way. We don't have any trouble, and we have everything to perform very nice reconstruction. So thank you very much. And if you have any question, I will be happy to answer to the question.
Thank you very much, Professor Francois, for your illustrated presentation. And actually, we have many questions for you. The first one is about if you confirm that your patient will receive the radiation therapy. If you know that very well before you start, you still recommend to use direct to implant or expander.
I do recommend to use definitive implants because of what? Because if the patient had a good result after the radiation therapy, she can preserve the implant and she had everything. She had the mastectomy and the breast reconstruction. If you use expander, you will have to go back to the OR and change the expander. About the radiation therapies, they do also prefer to have definitive implant because they don't have the metallic valve, the metallic magnet on the expander, and we know that when they perform the treatment planning, sometimes they have difficulty to give the good dose to the patient because of the metallic valve, and they do prefer to have definitive implant. That's why today I do prefer to use definitive implant for all these reasons.
Okay, another question about your protocol.
I'm sorry, I cannot hear you.
Now you can hear me? Yeah.
Can you repeat the question?
Yeah, you can hear me now?
Yes, I can hear you, yes.
Yeah, okay. The second question is about your protocol in the drain and antibiotic use with the TI.
our protocol about drains.
Yes, and the antibiotic.
And antibiotic. Okay, so before the surgery, the patient receive single shots of IV antibiotic, and that's it. We don't use post-op antibiotics. And then about the drains, we put 1 or 2 drains in the implant pocket. Then we remove the drains when the flow is under 30 cc's a day. And the main drainage time in our study is about 8 days.
8 days.
Yes.
Okay. And another question was the most common question in how to select the implant volume, calculation of the implant volume, that when you don't have the sizes.
Yes. So in Gustave Roussy, we are very lucky because we have a large volume, a large panel of implant, and we can use sizer. So if you cannot use sizer, and I think in Egypt you are like us in France, you don't can use a shape implant. You have only smooth round implants. So when you use smooth round implants, you have to choose and to take it into account the base of the breast. This is the main measure that you have to take, and probably we can speak about this later. But you have to measure the breast base. And usually you remove 1 or 2 centimeters, and then you have the base of the implant. And then before the surgery, you have to measure the projection of the implant. When the patient is in standing position, you measure the projection of the implant at the level of the IMF. So you have to take 2 measurements, the base and the projection, because we use smooth round implants.
Okay, and you mentioned in your presentation that the obesity is one of the contraindication or relative contraindication for the DTI or the reconstruction in general. And so the last question is about the cutoff BMI that you can perform DTI.
We don't have any cutoff. First of all, we know that usually when you have overweight patients or obese patients, they have also very large and big breasts. And usually implants are not a good choice to do the reconstruction. The thing that you can do is to do skin reducing mastectomy with the inverted T pattern, and then perform breast reconstruction with expander or implants, but usually we don't have so much good results. We can try to perform autologous reconstruction for this kind of patient, or to delay the reconstruction. So we don't have any cutoff. We can try. We can give the patient the opportunity to do the reconstruction, but we have to say to the patient that she had a high risk of complication and high risk to remove the implants a few weeks after the surgery. So, and for example, if the patient is smoker, obese, and she had big breasts, I do prefer not to do everything, send the patient to the adjuvant treatment and to perform a very nice breast reconstruction after the treatment.
Thank you very much for your explanation for all the questions. And now, as you know, we have the same problem in Egypt about the meshes and the cost of the meshes. So we used to do a direct implant with the marionette sutures subpectoral without mesh. And we have some complications in some cases. So we have 4 cases today to discuss with you and Professor Nicolas about the optimum decision for the correction. 3 cases with direct implant, and 1 case with a combination of latissimus dorsiflap and implant. And now my colleague, Dr. Abdulrahman, will present the cases. Dr. Abdul.
Assalamu alaikum. Hello, everybody. It's my pleasure to be with you today. Our first case, 25 years old female patient with a strong positive family history presented with wide breast mass. Sonomammography and MRI show diffuse white suspicious infiltration. Biopsy showing invasive ductal carcinoma, triple negative. Clinically, she was T3N1M0. Patient received neoadjuvant chemotherapy, then nipple-sparing mastectomy and direct implant was done. Was round implant 350 cc and marinate suture was applied. Then received post-operative radiotherapy 1 year ago. Now patient is complaining of pain and deformity with flattening of the nipple.
So back to Professor Nicola, what's your opinion to do correction for this patient? As you see, there's a flattening of the nipple, and she's complaining of pain and asymmetry, and this is the MRI picture for her.
Just a question: did she have a retropectoral implant? It was a retropectoral.
Yeah, it was subpectoral. All cases with subpectoral implant. We use a marionette suture to fix the lower part of the cutted pectoralis major to the skin. Then we remove it 1 week after surgery. So it is a subpectoral implant, rounded 350 cc.
Okay. So for this lady, it seems that her first demand is the function. She's complaining about the pain.
Yeah.
So I think we have to discuss with her if she wants us to continue to perform an implant-based reconstruction, or if she's demanding to convert for autologous reconstruction first. Because this patient had radiation therapy, she had some functional sequelae due to the treatment, and few of these patients they consider that it's done for the implant and they are demanding for autologous reconstruction. So the second stage can be also the opportunity to convert for autologous reconstruction. If the patient is still demanding for an implant, I think that for her, the first things to do is to convert for prepectoral reconstruction first. To do it means that by this way you will replace the muscle in the right position, so it will be an anatomical position, and then the patient won't complain anymore about the pain. So it's very important for her. If you go for a prepectoral reconstruction, you will be able to recreate a new pocket, a tailor-made pocket adapted for the new implant. So it means that you can improve the aspect of the breast just with the new implant and new pocket. You will perform some capsulectomy, and especially in the lower part of the implant. And I think that if the skin is quite thick enough, you can eventually perform during the same stage a first session of fat grafting, just to make the tissue coverage thicker, and especially in the upper part of the breast, where the visibility of the prepectoral implant will be more important. So I think it would be for me the first step to go for prepectoral reconstruction, capsulectomy, and fat grafting. And few months later, something about 4 months later, you can consider eventually to redo some fat grafting and eventually to think about the left breast symmetrization.
Okay. Do you mean that we will use a mesh with the prepectoral one?
It's not always necessary during the second stage, because if you go for a new pocket, a prepectoral pocket, you can create the pocket exactly on the size of the new implant. So if you want to change the size of the implant, for example, if you want to make it to use one implant with lower width, you can adapt during the dissection of the preparator pocket the width of the pocket. So the use of the mesh is not systematic during the second stage. It depends mainly on the pocket that you have created.
Okay, and what about the nipple reconstruction in her? Because the nipple is flattened.
Yeah, so for this lady, this is the most simple problem to fix. I would say that the better indication for her is to harvest half of the contralateral nipple and to do a graft nipple.
Nipple sharing, you mean?
Sorry?
You mean nipple sharing, you harvest?
Exactly, yeah. Because by this way, you will have the same nipple size, the same nipple color, and the patient will be quite happy.
Okay, so your recommendation is to convert to prepectoral reconstruction with new pocket and nipple sharing from the contralateral side.
And nipple sharing has to be performed probably later. There's no need to do it during the same stage. You can do it under local anesthesia in another stage.
Okay, with fat grafting in the first stage to improve the quality of the skin.
At the same stage than the implant exchange.
Yeah, okay.
So you can inject directly inside the skin flaps and also directly inside the upper part of the pectoris major to fill the décolleté.
Thank you very much. And the second case?
Yeah, our second case is the 30 years old female patient presented by right breast mass. Mammogram show right breast multicentric lesion. Biopsy came as invasive ductal carcinoma triple negative T2N1M0. Patient received first neoadjuvant chemotherapy, followed by right nipple sparing mastectomy and tissue expander, and received post-operative radiotherapy. Then the expander was replaced with anatomical silicone implant with left prophylactic nipple sparing mastectomy and diameter implant with marionette suture in the same session, was in October 2018.
Okay, this is the picture now. Professor Francois, the patient is complaining of asymmetry and nipple deviation for the side that does not receive radiation therapy, or for the left side, and she is satisfied with the right side. And this is the picture for the lateral view of the, this is the main concern for her, is the lateralization of the nipple, and she's satisfied with the right breast.
Okay.
And this is MRI picture. She's athletic and she's focusing about her movement and the daily use of her hands. So your recommendation?
Just tell me, the patient has radiation therapy on the left side, right?
No. The right side was invasive ductal carcinoma, and she received radiation therapy on the right side, and she's satisfied with the right one. But we do prophylactic mastectomy, nipple sparing mastectomy in the contralateral side when we changing the expander and putting the implant on the diseased one. She asked for prophylactic mastectomy of the left side, and as you see, she's complaining of the nipple lateralization, and the IMF is lower than the contralateral one. Regarding the right breast, that received radiation therapy, she's totally satisfied with this. Even with breast animations, it's okay for her. The main complaint is about the nipple deviation for her and the laxity of the skin hair that does not receive radiation therapy, and the low IMF.
Okay, so we have many differences between the two breasts, and on the left side we have a complete retraction regarding the skin incision. We have also bigger implant, I think, in the left side, and I'm not sure we have IMF lower than the right one, but probably we have a bottoming out effect, because when you look at the lower pole of the breast, and if you measure the distance between the the inferior border of the neck and the IMF, the skin length will be higher than the right side. So
Yeah,
probably
you mean this distance, Professor?
exactly. Because when you look at the level of the IMF, I'm not sure you have a huge difference. So probably it's a very difficult case. And about the axis of the breast and the position of the neck, it's better to have the picture before the surgery. Probably the patient had this position of the neck before the surgery, so this is something very difficult to correct. But probably I will go back to the surgery. The good thing is that the patient doesn't have any radiation therapy on the left side, so you can perform scar revision, replace the implant and put the implant in the perfect position according to the neck position, probably a little more laterally to refix the IMF. And I think in that case I will use ADM just to fix the implant in the good position and to have a skin retraction.
Okay, and what about the laxity? You mentioned in the right left the skin in here from the neck to the IMF.
Yes, it's because of the weight of the implant, and because probably you have all the weight of the implant on the skin, and this is one of the benefit or ADM or synthetic meshes. When you replace the implant in the good position, if you put a smaller implant, you will have a retraction of the skin on the implant because the patients didn't have any radiation therapy. And probably you can say again, I think on the left side it's 550 cc's, and what is the volume of the right side?
The same was 550 cc anatomical.
Five. I think it's the same implant on the both sides.
Yes.
Okay, so probably I will put a smaller implant because it seems that the implant is a little bit bigger, and I will put it more laterally to have a very nice definition of the breast on the external part, and use meshes to have a good position in the implants.
Okay, and you don't was planning to do mastopexy, just to do not mastopexy around the nipple?
No, I'm not sure. I will try with I will trust the skin retraction. I will replace the implant in the good position. Probably you can do fat grafting. But during this first stage, I'm not sure I will do mastopexy. If you do mastopexy, the neck will be higher, and when you look at the neck, they are in the good position at the same level. The only thing is you have excess of skin in the lower paw. What you can do is to remove some skin in the lower part, but with the skin retraction, I think you can correct this.
So you conclude that we have to do a scar revision for this.
A scar revision, implant exchange, put the implant in the good position, and afterwards, if you have a good definition of the breast, good volume, if you need to remove excess of skin, you can do it in the second time. But I won't do it during the first stage. I don't know, Nicola, if you agree with this, but this is the thing I will do for these patients.
So, Professor Nicola?
Yeah, it's a good idea. It's a very tricky case, and yes, probably the main problem for this lady is the left side with a malposition of the left implant. So just with implant replacing, you can eventually use a lower implant, and you can place it more laterally. You will achieve better symmetry and better result.
Okay, thank you. And going to the third case.
Okay, our third case is a 40-year-old female patient presented by right breast ill-defined mass, contrast-enhancing sonomammography, showed diffuse suspicious infiltration. Biopsy revealed DCIS, ductal carcinoma in situ. Patient underwent right skin sparing mastectomy with LD flap reconstruction. Then she underwent bilateral augmentation with 350 cc rounded silicone implant in the right side and 300 cc in the left side in June 2019.
So this patient is complaining of right breast asymmetry, and she needs for sure a right nipple reconstruction. So your recommendation, as you see that we augmented the left side with 300 cc round implant, and after we did the LD flap on the right side, after 6 months we put also an implant on the right one, and this is the lateral view of the right breast with asymmetry and deformity in the upper pool. And this is the lateral view of the contralateral side, and this is the final image for her. So, Professor Nicola, your recommendation?
So it's a very interesting case. Probably during the clinical examination, there's one thing to assess is does the patient is complains about breast animation? Is there a breast animation on the right side or not?
No. It's an LD flap. The implant is under the LD. There's no breast animation. Just the
lack of volume.
Yeah. Like
okay. But there's no contraction of the latissimus dorsi muscle. It's completely soft.
There is a contraction, but it's not annoying for her.
Okay. Okay. So if there's no complaint about the breast animation due to the contraction of the LD, there's no need to do a resection of the nerve. Okay. The main problem is a lack of volume on the right side. So there's different ways to fix it. You can eventually consider to do fat grafting only on the right side. So you can repeat the sessions of fat grafting on the upper pole of the right side to progressively fill the upper part of the right side. So it can be done. I think for her, you can eventually perform 2 or 3 sessions of fat grafting. So it means for this woman, ambulatory surgery. It means probably shorter surgeries with a short recovery, and the benefit of the liposuction of the abdomen or of the thigh. So it can be the first option. The second option is eventually to reduce slightly the volume of the left implant. That seems to be probably too big compared to the right side, and eventually to increase the size of the right side, you see, to change eventually the shape of the implant, to have a higher implant to fill more the décolleté. And during the same stage, when you perform this implant extension, you can also do some fat grafting just to complete the fill of the décolleté. So I would say 2 strategies for her: fat grafting only or fat grafting and implant exchange. And the last thing that you can offer to this patient is eventually a scar revision on the lateral part of the right breast, because you can see on the left picture, there's 2 folds: the fold of the scar of the LD,
yes,
and the fold of the infrared fold. And it means it's not so natural. So as much as possible, we try to place the extremity of the scar of the LD exactly at the same level than the natural infrared fold, to avoid this aspect of double fold. Okay. So if the patient is complaining about that, you can make eventually just a scar revision to make a single fold on the lateral parts. And later, at the end, when you have complete the reconstruction and you achieved a good breast symmetry, then you can eventually perform a nipple reconstruction.
Okay, so I will conclude that you said that we will start with fat grafting for this asymmetry of the upper pool and with scar revision, and after about 3 sessions we will achieve almost what we need from the décolleté and the upper part. And in the last one of fat grafting, we perform the nipple reconstruction.
It depends. You can do it during the same stage of fat grafting, or you can do it under local anesthesia in your consultation room. So it's up to you. Yeah.
Wait.
And the second option is implant exchange.
She's very happy with the left
okay.
one. So,
Okay.
so it's,
but if she's happy with the left one, you can eventually just increase the right one.
Yeah.
It's also an option, but it means a longer surgery, the drains, longer recovery. So it's not the same.
Okay. Thank you. And the last case.
Here, our last case is 36 years old female patient with strong positive family history, presented by left breast mass. Sonomammography show left multicentric malignant mass and wide diffuse microcalcification. Biopsy from left breast came as invasive ductal carcinoma, and twice right-sided biopsies revealed fibroadenosis. Patient was discussed about prophylactic mastectomy on the right side. Patient received neoadjuvant chemotherapy at first, followed by left nipple-sparing mastectomy and right prophylactic nipple-sparing mastectomy, and DTI on both sides by rounded implant 450 cc. Post-operative pathology of the right side show focal ductal carcinoma inside. Patient received post-operative radiotherapy on the left breast.
So, Professor Francois, this is the case now. She performed nipple-sparing mastectomy post-neoadjuvant chemotherapy on the left side with direct-to-implant using a subpectoral pocket with marionette technique. And in the same session, we do from the infralateral incision, right nipple-sparing prophylactic mastectomy, that the pathology of it came with focal DCIS. And she received radiation therapy on the left breast, and she's now complaining of the asymmetry and loss of the volume here. And this is the lateral view of the right one that does not receive radiation therapy, and of the left one. And she is asking for correction of asymmetry. Professor Nicola?
Yeah. So for this, just to be sure, so she's happy with her implants.
Yeah.
So she wants to keep implant-based reconstruction on both sides.
Yes.
Okay, and she's happy with the right side, and she just wants to achieve the same result on the left.
Okay.
And does she complain about the breast animation on the left side, about the pain or something else? Functional.
She was complaining of pain, but the pain improved with time after radiation therapy. She ended radiation therapy. Then there is pain, and the pain gradually improved. And there is no complaint of breast animation. Mainly, the complaint is the when she the defect here from this part and the flattening in the upper part. That's
okay. So this case is quite similar of the first case. I would say for her, we need to perform an implant exchange on the left side. We need to do a capsulectomy to make the tissue softer. And again, it's an indication to go for prepectoral to release the muscle, to replace the muscle. And by this way, we can eventually create a new pocket more medial, because it seems that the left implant is too lateral. So yes, we can replace the implant more medially. And again, at the same time, we can do some fat grafting. So one session of fat grafting during the time of the implant exchange. And a few months later, you can redo fat grafting. And if the patient, another option is to do just one session of fat grafting and to see the the patient is happy or not. If the patient is very happy, you can redo more sessions of fat grafting without the need of implant exchange. So it depends mainly the patient. But I would say if you want to make it more symmetric, you need to make the implant exchange.
Do you recommend implant exchange with a smaller one and the capsulotomy or capsulectomy and the medialization of the implant, or we use the same one, we do undo capsulotomy and do it's more medial with fat grafting?
I think you need to take the measurements of the breast, the left breast, but it seems that the implant seems to be too small. So I would probably use a bigger one, slightly bigger one.
Okay.
Yeah.
And as you see, it's more lateral.
Much more. Yeah. On this picture, it seems to be just two lateral. So probably you can try with the same one, and if just by replacing it more medially could be nice. But I think you need also to do some fat grafting on the right side, because if you look on the implant on the right side laterally, you can see the rippling of the implants. So yeah. There's a benefit of
fat grafting
on both sides.
So you recommend that we do capsulotomy and the medialization of the left one and the fat grafting to cover the rippling on both sides. Is this a final one? This is a final recommendation?
Yeah, I would say, yeah.
Okay.
Fat grafting on the right side and implant exchange and fat grafting on the left. Yeah.
Okay. Thank you very much for your explanation, and I really appreciate your time and the Professor Nicolas and the Professor Francois. I really thank you for your support and your elegant presentations today. And I have to thank all the IT team of Bahia Foundation and all the participants. And special thanks to our coordinators, Mrs. Doha and Mrs. Sally. And thank you all. Thank you again. Thank you, Professor Nicolas. Thank you, Professor Francois.
Thanks to all of you. Take care, and hope to see you soon in Gustave Roussy. Bye-bye.
Sure. Bye-bye.
Thanks a lot.
Thank you.